First of all, thank you everyone for joining us for this evening. And we're going to be talking about menopause matters, myths and truths. And we've got a number of excellent speakers and expertise in their field. So I'm going to just get them to say a quick hello, which part of the world they're from, and sort of what role they play around this topic area. So I've got Noshina. So if you want to say
Thanks.
a quick hello to everyone.
Thanks, Raj. Hi, everybody. My name's Noshina Kiani, and I'm the workstream lead for cardiovascular disease at the Health Innovation Yorkshire and Humber. My specialist area is just looking at how important cardiovascular disease risk is around menopause and perimenopause.
Thank you. And Michelle Rowlinson?
Yep, so I'm Michelle Rowlinson. I'm in Norfolk on the East Coast. I'm a senior physio by trade, and I also am a menopause wellbeing practitioner. And I do workshops for businesses, health professionals, to try and educate people, because education is power to being able to sort of help ourselves, as well as getting treatment that we deserve from health professionals.
Thank you. And Allison Noel?
Hi, I'm Ali, and I've got a menopause coaching business which I call Menopause, because I'm all about transformation and empowerment. I got into that because I basically was put into postmenopause very suddenly through cancer treatment, and the symptoms were so unexpected, so that despite the resources I had a science background and lots of different resources, but I sort of in effect fell off a cliff, so I resigned this position. So basically I'm all about raising awareness and trying to support people basically to not go through what I went through and try and improve the life of others.
Thank you. And Melissa, she can't get her camera on because of issues, but Mel, can you hear us? Can you just quick introduction, who you are and where you're based?
Yes, I can hear you now. Hi, everyone.
Hi, Mel.
Hello.
Hiya.
So just introduce yourself briefly.
Yeah, sure. I think I heard quite a little bit, so I'm not sure what to say. But yes, I am Melissa, and I am originally from Zimbabwe. I'm a nutritionist by profession, and I focus on cultural foods as a nutritionist. So I've got my own nutrition consultancy business. I'm based in Bradford, and I'm also a director for an African community company as well. So I'm a mom of 4. And I like talking about nutrition in all aspects, as we all know that when it comes to nutrition, it affects every area of our lives, really. So I try to help out as much as I can. I think everybody was just kind of talking about how they got into menopause. I'm not sure if I heard well. So I'm not yet there. I'm still in my early 30s, but my inspiration of tapping into the menopause topic is because of what my mom went through. She was forgetting stuff, and she was talking to us about some of the things she was going through, but we didn't know that she was actually going through menopause. And I think there was quite a lot of guilt from not knowing what was going on and how we could better support her. Some of the times we're just like, oh, you just keep forgetting stuff. We keep on repeating stuff to you, and you forgetting A, B, and C, and we're not as sympathetic with her when she was going through, the symptoms or the phase that she was going through. So I just took it upon myself to learn more about it and talk to more women about it, especially from the African Caribbean community, what their journey has been like, what their symptoms were. So for the first time, I sat down with my mom and I said, okay, what was your experience like? What did you go through? And she opened up from there onwards. And then I was like, you know what? I'm in a position where I speak more to women, as I'm called more to women conference. So let me learn more about it. Let me do a bit more research, talk to more people. In that way, whenever I'm having a conversation with women, I can help as much as I can, because some of you may already know, some communities are not very open to menopausal treatment, and they just want to focus on, what can we do? How can I do? What can I do with my health? The foods I eat, the lifestyle. Most of our communities, they focus on food. Food is medicine. And me, with the experience and the knowledge and the qualifications I have, I just thought it would be great for me to know more about it so that I help a bit more people.
Brilliant.
So that's where I am.
That. Thank you, Melissa. And thank you everyone else for joining. And a bit about myself. I'm a Black Belt Mindset business coach, as well as author and speaker and martial artist. And I've been running a number of these online roundtable meetings on a variety of different topics. And obviously this is a very important topic we're going to be discussing today in terms of menopause matters, myths and truth. And there's a number of questions that I'll be asking the panel. And if you have any questions, then put them in the chat. It is recorded, so we can follow this up on a YouTube channel. So what are the most common symptoms of menopause and how can they be managed? Who would like to have a go at that first?
I think it depends on whether you want to sort of come from an impact point of view, or the ones that are well known, or it's quite a difficult one. I think we can list off some symptoms, but I think one of the things I'd like to highlight is the fact that sometimes it's the severity of some symptoms over others, but also if you get a cluster of symptoms occurring at the same time, the impact then can be far more. So for example, you can have something like hot flashes, night sweats, so you don't get good sleep. So you wake up the next day, you're feeling groggy, brain fog will be worse. Your whole productivity will be down, and then you can then have more sort of migraine headaches, that type of thing. And then it means that you end up maybe being a bit more stressed, so then you don't get into a good sleep, and it just ends up becoming a bit of a cycle. So I think that's one of the things that I think maybe isn't something that people talk about quite as much. It's that cumulative effect, but also the coming together at certain times, because as you can imagine, when your hormones are fluctuating, the symptoms can vary in severity too.
Indeed. Thank you, Ali. Michelle, what's your sort of...
Yeah, I think it's also important to sort of, we all know like the more common ones, hot flushes, night sweats, mood swings, but it's the array of symptoms. So like with me, gum issues, nearly losing my teeth, heart palpitations, or metallic taste in your mouth, or pins and needles, hair loss, acne. So there's estrogen receptors are in virtually everything. So virtually everything can be affected. And like Ali said, it's the severity of them as well that can, differ. But it's definitely, some women feel like, we were discussing how I felt like I had dementia because I literally would, go into a room and I couldn't remember why I'd gone in there, or, I'd find silly things like my phone in the fridge, because I literally felt like I was losing my mind. But yeah, there's so many, we don't realize that itchy ear can be a symptom, but bowel problems, so IBS is quite common. We've said, about insomnia, but it's not just not being able to get to sleep. It's often a 2 a.m. ping, you're awake and there's nothing more that's gonna, you just go, oh, here we go again. It's 2 a.m. Type of thing. So there are just so many symptoms. Obviously, some women can barely get one symptom, but some women can definitely be hit with a lot more. And it's just, we're all very individual. But it's just, if you're getting accumulation of suddenly lots of unusual symptoms, then it's seeing a pattern rather than
yeah.
And I think there is
well, isn't it? I mean,
you what? Sorry,
you could have.
Sorry, Ali, you've got to say something?
Sorry, it's okay. I think the line seemed to break up. I wasn't quite sure if there was one or two of us all trying to speak. I was just going to say as well, I think it's sometimes there's a lot of symptoms that aren't really spoken about. So people are aware of the estrogen falling and maybe your skin changing, but people don't realize that often it's internal tissue as well that is affected. So the whole vaginal dryness and atrophy can be one, people not realizing there's a link with increased UTIs. And like when we were talking earlier, just the fact that sometimes you can go to a GP with an issue and they'll say, oh, it's this or it's that. And quite often UTIs will be treated as something completely different. And yet what it maybe just needs is that quick amount of a vaginal estrogen just to make all that difference and just stop having these UTIs, because again, that increases some cumulative health impacts. And I think probably we'll all be in agreement, and Melissa will have lots on this as well, just the fact that you can make such small lifestyle adjustments that this can actually be quite an empowering time of life. It's easy enough to speak a lot of the negative sides, and it's good to have a good laugh at the symptoms really in many ways, but there is a lot of information, advice and support that can be available so that people don't need to fear this time. It's making sure you're informed so that the symptoms don't become you. You can actually still live a really good full life.
Yeah, and you almost need to embrace it, don't you? And like you said, it's all really negative, isn't it? It's like you losing estrogen, and you're going to get your bone mass and your muscles, and everything is giving way. But it's almost a chance to reset your life a little bit. So you would reset, so the diet and everything else that you had, the exercise that you were doing before, it's a chance to reset all of that and do it in a different way. Because like we were talking about earlier, we are living longer, but we're also living longer with a lot of long-term conditions at the same time now. So it's about how do you manage all of that and have a healthy, so you're living longer, but you're living a healthy life whilst you're doing it.
It's interesting. There's a question from Eddie. Part of my postgrad work was on bone density scanning, which is significant for for menopause. Did any of you suffer from bone density loss? Or is it
I haven't.
About bone density
but as a physio, obviously it's something that I work with lots of sort of resistance training. Again, down to diet, you can help with calcium, vitamin D. But ultimately it is sort of being active with your, sort of walking, dancing, things like, and then your resistance and weight work that can really help with that.
Thank you for that. Mel, I don't know if you're able to say anything on these topics at the moment. We want to come back to you.
What did you say, Raj?
Yeah, just did you want to add anything at this point?
Yeah, I think some of you were touching up on the symptoms, and I noticed that sometimes people talk about going to the toilet quite a lot. So on top of insomnia, there can be some, like, some of you were saying that everybody is affected differently. Some may not experience insomnia, but some may be going to the toilet quite a lot, and it can be a bit of a shock, like what's going on, because again the muscles in the bladder, they're getting quite loose, and sometimes they go, or maybe they think they finished and they haven't, and there's all these things that are not as intact. And when it comes to stress, sometimes the way we define stress is very different. But what I would normally communicate is if you're not feeling the same. So if you're feeling unusual to how you usually are, you're not engaging with the activities you used to like doing, you're always feeling low. Because in our community, when it comes to stress, you've got to reach to a certain level for you to say, yes, I'm stressed. But by the time we get to that level, it's probably at a point where we now need, that extra help. So a lot of people tend to say, no, I'm not stressed, I'm fine. But if you're finding yourself in a situation where you feel you're not your usual self, you're not liking the foods you used to like, you're suddenly disinterested in the things you used to like, you don't like meeting up with people, you're having different thoughts about yourself, about your body, about your life, and everything around you, that's when, again, you can pick it up that, you know what, maybe something is wrong with me because maybe I was an outgoing person, now I'm no longer, or vice versa. So that's another thing that I'd like to hammer on. If, again, you're not
Yes.
understanding more about stress and you're thinking it's okay, especially us within the African community, we endure stress since we are children, and it's something that we are accustomed to, something we're used to. So people might not identify or already link stress to menopause. They think it's just day to day.
Yeah.
It's just day-to-day work. It's just day-to-day racism. It's just day-to-day motherhood. It's just day-to-day looking after grandchildren. But then again, what are those extra little things around mental health that you should pick up on to make sure that, you know, you're linking things to the right stuff? So again, if you're not feeling your usual self, then again, I would say keep an eye on that.
There's also taboos, isn't there, around
Thank you,
mental
Melvin.
health, stigma around mental health as well. That for a lot of communities, you wouldn't necessarily go and visit a doctor about that. Hence, if you were coming towards that menopause transition, it would never be picked up as menopause or perimenopause, depending what age you came in at as well. They would just see it as something else.
That's interesting, because the mental health and well-being, you know, I suspect that there may be some mood swings, depression, because sometimes it's not been identified by doctors. I mean, Michelle, earlier you were talking about how much education or lack of education there are for general practitioners. Would you like to say something about that, and where you can go to educate yourself?
Yeah, I mean, unfortunately, it is well, fortunately it's changing, but unfortunately GPs that are currently in surgeries get less than sort of a couple of hours of training. It's quite poor. And actually it should be, my aim is to try and get all health professionals trained that see any women, because on my journey, the dentist didn't recognize that me having to spend a lot of money to stop my teeth falling out was hormonal. My cardiologist didn't recognize that my heart palpitations were hormonal. My optician didn't know about perimenopause. She ended up buying my book because she realized that many women are coming in with dry eyes, eyesight problems, and that she was perimenopausal. But as a physio, we're trained to know that women 40 plus are more predisposed to frozen shoulder, tendinopathies, joint pain, but I didn't know why. And I remember significantly loads of women saying, God, I feel like I'm falling apart, and what I was treating was helping that bit, but I wasn't treating the cause. So this is why, that I trainee GPs in my local area. Because one, I like to educate women. So with my workshops with Age UK, or in my menopause groups, things like that, so that women have the power to have the conversation with their doctor, or know how to talk to their doctor if the doctor isn't very well educated on menopause, so they can sort of have things like journaling their symptoms, not going piecemeal like I did. Because it makes it easier for a doctor if you go armed with all your symptoms, whereas I was going, oh, I've got acne, and then the next month it was something else. And then, so to be fair on the doctor, that's why they kind of went, oh, you're stressed, have some antidepressants. Oh, here's some cream for your acne. Here's this. But in the end, they just sort of made me feel like that it was just one thing after another. But definitely, I think if women are educated and health professionals are educated, you can just have a much better understanding. Yes, always rule things out. Never just assume it's perimenopause. We mentioned like metallic taste, that can be something else. So you must always check symptoms, but once everything's ruled out, having that conversation about, okay, do you want HRT or diet and lifestyle changes that can help? So it's definitely just having that conversation.
That's interesting. Noshina, I mean, the role. talking about? Is it?
I was just going to chip in on what Michelle just said. I was just going to say, even about those HRT conversations, you almost feel like if the GP has prescribed something, you're supposed to go away and take it. And then if it's not working, women are not going back again to say it's not working. And I think that's the thing. You kind of try something and then you leave it because it's not worked for you, and then you ignore it, and then the symptoms get worse. But I think the thing, what you were saying about the education, is you need to go back to the GP because there's lots of alternatives. There's no one size fits all approach with HRT. You've got to find the balance that works for you. And it's not the balance that it worked for your mum and it worked for your sister and it worked for your friend. Everybody's genetics and body is different. So you need to find what works for you and what makes you feel better. What you were saying about that, are you starting to feel, because everybody kind of says, I don't feel normal, I don't feel like myself, I've lost myself. So when it's about when you are, do you get the medication? If HRT is for you or other medications are for you, it's about going back and having a mixed approach where trialing something for a bit, seeing if it works, then going back and having the confidence to go back to the GP and say, this is not working for me, what else could I try? And then trying something else and then going back until you find the right mix that works for you, and not just trying it once, because I think that's the problem with a lot of this, where women will sometimes go in, and again, it's that lack of awareness where you'll try something and you'll just be like, it's not working for me, so that's it, I'm kind of done. And then you leave it, and then the symptoms get worse and things like that. So I think it's about that education piece of being, you need to find what works for you. And there's lots of things out there right now.
And I think the other problem is you've got the woman that thinks, oh, that's it, it's not worked. But equally, you've got many doctors that actually think, oh, it's just the oral pill, or oh, it's just one dose, or it's just this. And I've had many ladies actually told by their doctor, oh, it's not worked, so you're clearly not perimenopausal. And so again, it's that education, which is what it all boils down to. It's education for everybody.
I mean, obviously there's a hormone replacement therapy, and there's sort of natural remedies that we could talk about, and lifestyle changes. And what can we talk about in relation to HRT? Because it's been around for some time. What are the risks, and what are the benefits? I'd like to have a go at that one.
I'm happy to, but I don't want to feel like I'm hogging the...
Go for it, Michelle.
I mean, the trouble is HRT has been given a really bad name by the trials, which scaremongered a lot of women. And even though it's still a small risk, it's the oral one that has the majority of the risks, with blood clots, so it has more contraindications. Women that are diabetic shouldn't take it. Women with migraine shouldn't take the oral one. Obese or history of strokes, things like that. But actually, the majority of women, and obviously we're all individual and all individual medical history, but the majority can take the transdermal ones. And it's just being aware, because again, I've had women told by their doctor, oh, you can't take HRT because you're obese. Oh, you can't take HRT because you're diabetic. And it's like, no, actually, go back and have that conversation of, what about the transdermal ones? Is that still, because there may be another reason he said that, or she said that you can't have the HRT. But there's many benefits, future benefits to taking HRT, again, for reducing cardiovascular disease, osteoporosis. We spoke about bone health, and even studies are showing dementia, that it reduces the risk of that, because it's more prevalent in women getting Alzheimer's than men. But and it's a myth that you're too old, it's too late to try HRT. While yes, you won't necessarily get the long-term benefits by taking it age 60 plus, but you will still get the short-term benefits of reducing symptoms. And again, it's more the transdermal ones that studies are showing that there's no reason why you can't keep taking it, whereas the oral one, that it's more of a, yes, sort of like six years or so. But There's lots of, it's not for everybody. It is definitely an individual case.
Yeah.
But particularly the body identical transdermal ones, where the body treats it as its own hormone, and it's not that, because with progesterone you've got progestins, which are the ones that again it's still minimal but slightly risk with increasing risk of cancers. But the progesterone, the body identical, there are actually studies are starting to show that it reduces the risks. So it's just sort of looking at all the pros and cons, and again, it's your individual case of what's right and what's wrong for you, and having that discussion with your doctor.
Thank you. Anyone else want to add to this before we go to the
I
question?
I don't know what the others think, but I mean, I always sort of think it's good to make informed decisions. And one of the things that always hits me is how somebody is quite often prepared to suffer symptoms because they are fearful of risks, but they've not actually equated those risks. So I had one lady I was working with who was adamant she wasn't going to even consider HRT, and I just said, well, balance up the risks. I mean, the thinking is that a glass of wine puts you at more risk of many different situations. She said, well, I have about 2 glasses of wine a night. And I said, oh, well, we might need to think about that one, let's get your hydration boosted. Alcohol's not great for some of the symptoms. But I said, that aside, I said, if you're willing to take alcohol, even though you know the risks in taking alcohol, and I'm not sort of trying to diss anyone that drinks here, by the way, it's just to use the example. You've made that decision. So it means that even though you've had the information, you've ignored it in effect because you've seen that it's more value for you to have those drinks. And I think when you start to sort of equate it that way and help with that informed decision, but as soon as people try things and their symptoms are alleviated and they can find themselves, they recognize themselves, they can feel more normal and they can live a more normal life, then it can outweigh the risks. And the other thing I've found out, and I wish I'd sort of thought to pull up the research, is there is actual evidence to show that even if there is a risk of breast cancer or any of the cancers, the long-term outcomes from having been on HRT are actually better for the recovery. So it's not also as bad as people make out, but there does need to, I mean, it's something we were talking about earlier, there does need to be so much more research and so much more resource put into women's reproductive health as a whole.
Yeah.
Yeah.
Definitely.
Mel?
I also wanted to add.
Sorry.
Go ahead, Mel.
Yeah, I was also going to highlight that some people think that HRT replace contraception, but again, talking about myths, that's something different from the structure to the combinations that are there inside the HRT treatment is completely different. So if there's anyone who's taking it and who's not on contraception, if it's something, I know again, when it comes to contraception, it's against people's faith and values, etc. Just be mindful if you are not in a position to want to conceive again, then please consider being on contraception or continue taking your contraception. So yeah, that's also another thing I wanted to add. And some people have different understanding on where it comes from. Back then, many years ago, it used to be derived from the urine of an animal, but now it comes from wild yam, and that's a vegetable, and it's safer. It's very identical to the hormones that are in your body, which makes it much safer. People are concerned with breast cancer, but if you are to look at contraception, there's actually a higher risk of you getting some of these complications that come with contraception compared to HRT. So please just bear that in mind. I think we still have a lot of work to do when it comes to talking about HRT and addressing some of these myths, just like what some of you were saying. People are comfortable with taking one, people are comfortable with contraception, which contains synthetic hormones. But when it comes to HRT, which contains bioidentical hormones that are safer for us, then you get all sorts of questions. So it will take time for some communities to start, getting on board with it. But I think we still need to kind of, educating people a bit more.
Thank you. I'm just going to go to the questions. There's one question, then followed by another one. Does anything like menopause care navigate? Anyone comment on
Sorry?
that? Does anything like a menopause care navigator exist in the NHS or an app out there or something like that?
Not that I'm aware.
Just tracking apps, but
Okay. All right, maybe someone can develop one. An opportunity there for whoever had the question. Another question: do you think that there's a knowledge gap in menopause? Says falling off a cliff shows how life-changing it can be, or do you think that menopause could result in relationship breakdowns, divorce, as there is anecdotal evidence that there may be a link with a spike in latter years?
100%. I mean, my marriage, not to say that we were necessarily meant for each other, but I don't think it helped that we got married the year that I hit perimenopause. And he must have thought he'd married a crazy woman with the rage. And I've seen so many aha moments in my workshops with men going, oh my God, that's what was happening. And again, I have to say, I don't know what your relationship was like, so I'm not saying that's the cause of, the breakup. But they were like, yes, she just changed and, and just suddenly left or this. But equally, on a positive note, I think it also makes, once our estrogen is stabilized and our brains kind of recalibrate, we also reassess things. And many women won't put up with relationships that actually are toxic and horrible. So you can have it in two ways. Why relationship breakups are more prevalent age 45 to 55. One is because it's either affecting women symptom-wise where they're not wanting sex or sex is painful and they won't talk to their partners about it, or their rage, mood swings, or it's affecting their appearance where they might not even put on weight, but their body composition changes, or they do put on loads of weight and the man then isn't find them, attractive, or actually they're becoming more stronger and going, why am I putting up with this moron who, or domestic abuse or anything? And they're actually going, no, I'm not putting up with this anymore. So it can be a positive reason why relationships are breaking up, or it can be obviously the lesser, or like we said, if you've got teenage daughters and hormonal, so it's just puberty in reverse, and the man in the middle going, I ain't putting up with this anymore. So,
But I think there does need to be sort of information and support for men as well, because it must be, I've certainly come across it, where they just haven't a clue what's going on, and this person that they thought they knew really, really well suddenly becomes very different, but they don't know how to help them either. So I think communication needs to be there, especially if the woman is either finding symptoms, sex painful, or is really not feeling very attractive anymore. Simple things like, sometimes, again, if you've got a range of symptoms, then sometimes sort of spending time with somebody isn't as appealing anymore. Intimacy isn't as appealing anymore. People change. I mean, I've had some funny situations. I mean, I'm saying funny, we could laugh at them because it was appropriate to do so. But, somebody saying, well, how can you expect me to want sex when the dishwasher needs emptying and you never do it? It's little things like that, or little habits that somebody has. Women can become a lot more sensitized during perimenopause to somebody eating loudly, or, just little habits that just start to drive them up the wall and cause this murderous rage, which is, again, another one that makes people laugh. But it's getting down to that communication and just talking, because it's knowing that there are quite often little things that can change, communication that can just make life a lot better.
Yeah, I'd agree, Ali. And even breathing, breathing of somebody, just little things like that are quite normal and quite sane, you become really irrational. And it's almost like you're trying to find yourself in all of this. whilst, like you said, it might be the men in your life, it might be your children, it might be your work colleagues, even what we talked about earlier, where the impact of what's happening is not just on you as an individual. So obviously you're experiencing it physically and emotionally and everything else, but the people around you are also experiencing this. And like you said, they don't know. So there is a knowledge gap. I mean, some of it is probably not lack of empathy. It's probably more the fact that they don't know about it. They can't understand it. There's, like you said about the communication, they can't help because they don't know what's going on for you. And if you're going through that phase where you're trying to work out, am I perimenopausal? Am I menopausal? Like, where am I at in this stage? It's really hard then for other people around you. So I think that the awareness that we've been talking about and that knowledge is not just for like clinicians and not just for you experiencing it. It's your immediate, like, who's around you at the time as well, because you can be educated and have all of this awareness, and then you go back to that environment where you're not supported again. So again, there's lots of friction there that could take place as well. So it's about you being supported and knowing what's happening, but also having the men or the other people that are in your life having some sort of knowledge as well. So they don't need to know all of it, but they, you know, if you're having a bad day, it, you know, they need to understand that actually you're having a bad day and it's quite normal. It's not that you're being difficult, and it's not that you're being angsty or anything else. They just need to understand some of the rationale behind those behaviors as well. So I think it's like communication, what you said, Ali, is really important for you and the people that are around you.
And that's definitely why when we did the 8-week workshops with Age UK, we had I managed to win it and get a bolt on so that they could bring partners or family or whatever. And then I did like the whole 8 weeks in like one session so that the men or the female partners or whoever they wanted to bring that was in their lives that didn't understand. And it was really nice to see like, oh, that's what she's going through. So definitely.
I must admit, I've started offering couples work just so that bit can be, and I try and always add a positive side, because I say, you know, menopause is a time where you don't, you know, once you have got through menopause, you don't need to worry about pregnancies. It can be a really freeing time. Quite often your children are at that stage where they've left the home. It's a freeing time. And so you can actually almost have that second honeymoon and start again. And I mean, that maybe sounds quite idealistic, but it's interesting how people talk. And I said, and you can reinvent your sex life as well. You know, there are lots of things out there. Maybe the woman needs a lot more wooing now than she maybe did before, because she needs to be in the mood. And there's lots of ways of helping if there are any symptom issues. You know, I mean, I remember the first time I watched this series called Grace and Frankie. I don't know if anybody's come across it, but they talk about lube. If you haven't seen it, it's great. It's on Netflix. Very, very funny. And yeah, it just adds a new, a comical way of just looking at things. But again, it's an important thing to address because it is an important part of relationships and communication, intimacy, and just having a bit of fun together.
Yeah, it's a massive change in relationships, and if the relationship is struggling, and then things changes in their life like menopause, perimenopause happen, and you don't have the education to understand about menopause. It does add a more difficulty to try and support and show empathy in relation to how we sort of differentiate between perimenopause and menopause, because not many people have heard of perimenopause in one sense.
Actually, according to the British Menopause Society, a third of women haven't heard of perimenopause before they start having symptoms.
And there's no test for it either, is there? It's all based on, I think the thing for me, again, that was kind of shocking is that your menopause is, you have 1 day of menopause. So we were talking about, I think I was talking about this at an event where we were saying that when you have a heart attack, you have it and everybody can see the symptoms and you're diagnosed and you're treated and everything else straight away. And I think what happens with menopause is you have to go through it for 12 months. So you have no period for 12 months. And then you have 1 day of menopause. And your life after that is postmenopausal. And then you finally realize that the 10 or 15 years before that, when you weren't feeling as you were, you were in perimenopause that whole time. So it's like a retrospective diagnosis. It's not even that it can be diagnosed. I know now people are talking about it, they're more aware, so you kind of spot it and you're like, right, I'm going into it, I need to do that preventative piece. But it's still not, there's no actual official diagnosis to say that you're in perimenopause, which is still quite shocking.
Yeah.
Yeah, I think some of the symptoms that people can keep an eye on is the periods they change. So, when you get to the menopause, that's when you've got no periods at all. But perimenopausal, your body is kind of, I don't know if we can safely refer to like changing or drying up. So things can be different. So maybe your periods start to get a bit longer, maybe they're spaced out in between or they're shorter. The patterns are different. And again, the way you feel within yourself, that can be something to keep an eye on. If it's something you start experiencing under the age of 35, I suggest that you please go see your GP, because again, it can be quite dangerous for it to go undiagnosed or unnoticed, because they can be health consequences. But just keep an eye on your periods. If they're changing, that can be also a cue that you're getting into perimenopausal phase.
I think when you're younger, it's also, that's the difficulty in GPs acknowledging it, because I was 32 when mine started, and I went through 7 years of hell before I worked out what was going on. When I did the training last year for the GPs, instead of introducing myself, I actually started with a case study that was actually me, but I didn't tell them it was me, and got them to say, right, just discuss. I know we're here for menopause, but discuss amongst yourselves what you would be thinking. And then when it came to it, and then I said, so what have you got? And one of the female GPs was like, she went, well, I know we're here for menopause, so that's going to be menopause. But she was like, that wouldn't even be close to my radar at 32 years old. And I was like, exactly. And it's more common than you think for peri to start to late 30s. If you think about it, if the average age is around 51 in the UK for menopause, and it can last up to 10, 15 years, it makes sense that in your 30s, I mean, it can last from 1 year, it can last up to, I was 11 years still perimenopausal when I had my hysterectomy last year. So I would be coming towards the end of peri, but and it is, that's the important bit, is to acknowledge that, one, it can happen at any age. There isn't an age. I've known women that are 60 and still having normal periods and going, when the hell is this going to happen? Because I'm still 60 now. And, or I've had women in their 20s, late 20s saying, what's happening? I'm late 20s, but I've got all these symptoms. So I say, get checked out, you should rule out other things. But, it is something that can happen at any age, but it's just more common late 30s, mid 40s for peri to sort of start.
And we were talking about the cultural differences earlier, weren't we? And if you're from a Black or South Asian community, actually, it's much younger than that. So you could potentially be experiencing it kind of 30 plus and heading in that kind of age, where actually a lot of people are thinking about having children at that age, aren't they? And I think what happens is, if you think about, like, when it comes to menstruation, you're taught that at school, aren't you? So at secondary school, whatever, you get a little bit, but nobody ever covers menopause for you during that time. And it thinks, well, actually, it kind of hits you at this age, and it comes as a bit of a shock because nobody's talked about it, and you think that it happens to you in your 50s, so it's not even on your radar to think about. And it's almost like that education piece needs to be done a bit sooner, not to scare people, but just to make them aware that the window of opportunity where you could potentially be much easier for you to conceive is actually much smaller than we actually think it is. And we've been taught that it is, because again, our bodies are very different. So we could be going into perimenopause sooner than most people actually think.
Yeah.
Definitely.
Yeah.
And actually, one interesting thing is, when you're in perimenopause, yes, it can become more difficult to get pregnant, more susceptible to miscarriages, but actually we're also more susceptible to twins, which is When I found that one out, I found that quite funny because we've got quite a history of twins in my family. And I was like, oh God, almost scared of getting pregnant in case I had twins, which I was 23 when I had my son, thankfully. But my cousin, who's only a year younger than me, she had twins at 40. So, and all the women in my family are
Wow.
35 plus who have had twins.
Yeah.
You're talking about sort of Asian and Afro-Caribbean background. Is there any health inequalities in terms of, provision of service?
Yeah, there's huge health inequalities. I mean, there's language barriers for people. There's the language barriers are so important. There's the cultural modesty as well for some people. They don't want to go to a health provider if it's male. They might not. We were talking about the mental health thing earlier, where there's a taboo. Never say that actually they're stressed or they're suffering from mental health, because that's not what they do. They just carry on with life as it is. So I think there's lots of things that need to be done in terms of trying to explain the situation as well to people who might have those cultural differences. The diets are very different, that you will know about. The diets that they're used to, their dietary habits, they're more at risk of things like osteoporosis and fractures kind of in that postmenopausal. So yeah, there's lots of genetics and other things at play here. And the health inequalities, like I said, I think just the fact that actually Black and South Asian women experience it much sooner and not a lot of people know is a massive health inequality in itself, isn't it? And that's not just for it's for people knowledge as well. So yeah.
And also the fact that when you say down to diet, also the fact that Asian women typically in their own culture and environment actually tend to not have menopause symptoms as badly as Westerners because of their diet, because of phytoestrogens. They're more active. Westerners, we're sat on our backsides on a laptop now. We don't get the exercise we should. We're eating fast food, rubbish food, which are all inflammatory type foods, which of course estrogen helps prevent inflammation. So as it decreases, our inflammation can go up. So then eating inflammatory foods on top increases it. So it all becomes a bit of a vicious cycle. But yeah, definitely culture has a huge impact.
They're also less likely to be on HRT, again, because of some of those barriers. They don't understand it. It feels really complicated. They don't have those kind of, they don't make GP appointments. And then it has we know that there's a low uptake of smear tests. They don't go for breast cancer screening. It's about raising awareness of all of that, isn't it? It's not just the one. And the menopause bit is an area of that. But the increasing awareness around smears and breast screening, they're also equally important. So I think it just needs to be that kind of inclusive education for all. And how do we get those messages across to people?
Thank you, Mel.
Absolutely. Yeah, I still think even till today, there are some. Can you hear me?
Yeah.
There are still some general practitioners, because again, that training is, I think, voluntary at the moment. I don't think it's gone mandatory where every GP is supposed to know about menopause. So again, if someone is to go and say, okay, this is what I'm experiencing, like what one of the speakers was addressing, they're just going to prescribe antidepressants and, to fix one problem or the other. And again, we've got the cultural bias that when a Black woman walks in and say, I'm experiencing stress in A, B, and C, the first thing he's not going to think about is menopause. Is probably, okay, go try and exercise or do A, B, and C. So there's a little bit of ignorance that can be there as well, or maybe cultural incompetence, I'm not sure. And then again, on top of that, the advice that they get about the diet, again, it's not cultural tailored. So I think on the GP side, I may come knowing that, okay, this, what I'm going through is not my usual self and I'm experiencing quite a lot of symptoms. But then again, if the GP that I'm seeing is not aware and is not up to par with the training, they might not be able to identify and prescribe stuff that actually is not going to help me. So what I would say is, be comfortable with getting that second opinion. Always get a second opinion. If you get something and you're not sure, and maybe you are certain that you're getting getting into the perimenopausal phase or menopausal phase, please get that second opinion.
Thank you. Yeah, making sure that.
Just wanted to say that with the education side, it's mandatory now for students at university.
Sorry, carry on.
I was going to say it's now this year's academic year is the first year that.
Mel, I think you're not coming through clearly. So if you could mute for the moment.
But yeah, so
the time that's there for them to give you a proper diagnosis.
Come back.
Can you hear me?
Now, yeah.
Yeah.
Yes, I was talking about the time that if you are coming and you're trying to explain a 5 years worth of journey in 10 minutes, that's not going to be enough time for someone to comprehend or to give you a proper diagnosis. So those are my pinpoints, that try to get a second opinion if you feel that the diagnosis being given is incorrect. And yeah, just, go out there, speak to menopause experts if you think you are there. And sometimes you can track in the family history. If you know some symptoms that you've seen in your parents or people around you, and you feel it's a bit earlier, they might read or they might be taught that maybe it starts at 40, but for you, it starts a bit earlier. And then go seek that second opinion from a menopause expert.
Thank you. Michelle?
Yeah, it was just to say that this is the first academic year, 24-25, that it will be mandatory for doctors to learn about menopause and endometriosis and things. But the only problem is that by the time they've got graduated and they're in the system, it's still going to be a good 5-8 years before we start seeing those GPs in surgery. It's not mandatory at the moment, which is what I think it should be for qualified doctors to do it. So that's where we've still got the gap for quite a few years.
Thank you. Got a few minutes left. So sort of lifestyle changes, and those type of things that we can do in terms of nutrition. What can we say about that?
Yeah, so I'll talk with regards to our cultural foods.
Mel's on a train, that's probably why the signal's poor. You still with us, Mel?
Well,
Maybe going through a tunnel. Sorry, Mel, I think you're still not coming through. So while Mel's trying to get sound come through, what can we say about nutrition and lifestyle changes? And there is a question here.
Well, some really simple ones is like starting your day with a glass of water and keeping hydrated through the day. I mean, that's the most simple one. It's one of the first things I would say to anybody I was working with. You start, your brain is 85% water, and you wake up in the morning, your body's dehydrated, so it just sets your body up for the day. To get hormones working optimally, then it's that good hydration that's there. And then I think it's just working through. I mean, Mel hopefully will catch up and she'll probably be a lot better.
Yeah, I'm back in. Thank you.
Oh, good.
Sorry, I'm traveling to London, so the journey is a bit difficult. If it's okay for me to jump in before I get cut off again, would that be okay?
Yes.
Yeah. So I was saying, when it comes to communities, they do recommend, but it's about cooking the foods properly and in the right equipment. So first of all, when it comes to vegetables, people tend to boil the vegetables, and by the time you eat it, it doesn't have the nutritional value, or it's lost the stuff that's meant to protect you from harm, or to stop the harm that's going on in your body, or the inflammation. So that's the first thing. And then we move on to carbs. I've found it that when you're talking to certain communities and you're talking about brown rice and stuff, that doesn't stick. But what I normally advice is, again, cook it properly in the right and have smaller portions of the carbs that they eat, because food connects people to their culture, to their community, to their family. So if it's processed carbs that they're used to, then have a smaller portion of that, and maybe for one meal. So for example, if you're eating rice, instead of having white rice morning, lunch, and dinner, you can have white rice in the evening or once a day, and then in the breakfast you can have wholemeal bread, for example. So if you have a little bit of a play around with your carbs in smaller portions, that tends to help. And then when it comes to meat, I know people like to fry their meat. In some communities, people like their fried chicken, they barbecue their meat, and also they're using non-stick pans, which tends to have some forever chemicals. That's something I think at the moment that's not being spoken of, but those forever chemicals, they can cause inflammation in the body and eventually can make symptoms a bit worse. So just keep an eye on how you're cooking food and where you're preparing your food, because some of the equipment that we tend to use can contain forever chemicals.
Okay, Mel, thank you for that. I think we're starting to lose you again. There's just one other point I want to raise on here. It's quite important. I know we've gone over time, but I think it's important. We've got a solicitor here. And under the Equality Act 2010, there have been some cases that menopause is a protected characteristic. So employers must not unlawfully discriminate against those with menopause in the workplace because of their symptoms. I suspect that many have lost jobs because of it, or
well, interesting enough, there was
like to see.
Yeah, interesting enough, there was some lobbying done with Keir Starmer before Labour got in, and what Keir had agreed to do was, it's not just making it mandatory that menopause policies have to be in place, but there has to be implementation. I mean, I used to be an ops manager in the charity sector, and that's one of the things, anything change-wise, it's the implementation that's the hardest bit. It's not just having the policy. So I think what hits me is employment law has always been quite a toughie. I was with Citizens Advice for a long time, and discrimination in any form is wrong, but it's sometimes very hard to get justice. And by that I mean, if an employer wants rid of somebody, they will find a way of doing it. But what it is just getting that dialogue so that we're having more supportive communities. I mean, when I do some work with organisations, I sort of say, are you concerned about the retention rates of your staff? Have you looked at sickness levels? Have you looked at people taking holiday when, really they're trying to cope with symptoms? What's your workplace morale like? What's job satisfaction? These are things, when you throw at somebody the values they have in their organisation, it's all very well doing lip service to those values, but actually you can challenge people to say, walk the walk, don't just talk the talk. You can have this wonderful statement, but actually if your organisation isn't adhering to it. So, I mean, I think the Equality Act was a really great piece of legislation for bringing all the different forms of discrimination legislation together, but there's still a lot of work to do to really make sure that we don't just have equality, but equity as well.
Yeah.
Indeed. Now, we could go on talking for some time on different topic areas. And I just wanted to say, a massive thank you to Noshina, Michelle, Ali, and Mel for a wonderful roundtable discussion today on menopause matters, myths and truths. And this will be recorded, so you get a chance to review it on the YouTube link we're sending through to those who attended or those who missed out. The other topics we'll be looking at in the new year, and one of the topics is going to be endometriosis. So that's going to be really interesting as well. So look out for that, and bullying in the workplace, and a whole variety of different topics. So thank you once again to everyone for attending, the questions that you put forward,